You guys ready to talk about patient satisfaction? Are you feeling like you've been waiting for this all day and you want the full 30 minutes? Or do you kind of want me to condense this down? If you took a look at this chapter, the knucklehead that wrote it put 52 abstracts in here. So I will take responsibility for that, but I don't intend to speak about all of them. We'll just summarize all this. There's only so much you can talk about and say about patient satisfaction. But there are some pretty important things in the literature that may help you. So a couple initial thoughts. You know, in the past, we used to think that patient satisfaction was kind of just like a pet project of some middle manager at the hospital, and it was an aggravation to us. Now we know it is somewhat of a surrogate marker for ED and hospital market share. Is there any CEO at any of your hospitals that's not interested in patient satisfaction at this point? No, you won't meet one. Because they know if patients are not happy, they're going across town, they're going somewhere else. They'll drive substantial distances to go to a place where they're happy, they're seen more quickly, and they feel like they get better service. Anyone being compensated for patient satisfaction? I am, and a few of you also. Anyone being measured? Everybody. At this point, everybody. A few years ago, not as many hands went up. But you know, what's interesting, a lot of people who really don't like to deal with patient satisfaction said, you know, the data isn't good. We don't have really great data to support all of this. And they were like conscientious objectors. I would do it if there was data. If I knew that it was good, I would make the effort and be nicer to people. You know, but we know now that there is enough data. There's at least 52 abstracts we're going to look at here. This isn't randomized controlled trials about being nice to people, but there really are some good salient points you can take away about this. And there's some real good value in doing this. All right, so let's just jump right in here. What provider characteristics relate to patient satisfaction? I'll summarize abstracts 1 through 10 for you. We know that there's a pretty reproducible list about things that you do that are likely to please patients as opposed to aggravate them. There's also a pretty good list out there of things that if you do them, you're going to piss people off, and you'll do it every day. You know, I'm always amazed at physicians who are surprised they get ones on their Press-Ganey surveys, and they're frustrated because the drug seeker was there. You know, and I said, well, tell me about your interaction with the patient. Well, it's that same drug seeker that comes in all the time. And I told them so. I told them to get the hell out of the ED. Are you surprised that they gave you ones? If you don't want to prescribe narcotics to that patient, there's another way to approach it. I'm very concerned about you. I don't want to further an addiction problem because I care far too much about you. I can't do what you're asking, so here's some lovely Ultram. Have a nice day. It's a better way of doing it, same result. That's a 5 on a survey, not a 1. When you swear at people and tell them to get out, it's always a 1. I don't know why people are surprised by that. All right, so let's look at a couple of these abstracts. Tom's article, it's abstract number 1. There was patient satisfaction looked at with family physicians, and they really decided that trust was the big important factor that drove patient satisfaction. 5 items with it. Comforting and caring, demonstrating competency, encouraging and asking questions. That's the kiss of death in the ED, isn't it? So you're here for your ankle sprain. Anything else I can help you with? You don't want to do it. You got to do it. They're already there. They waited their time. What's that?
Something else I can help you with.
Something. Yes, something. Yes.
Yeah. There's Rick and Jerry
yes.
article in their database that anything kind of suggests I don't want you to ask me a question.
I think it depends on how you deliver it. You're right. There is a nuance in literature about something, but if you really are honest about it and have some eye contact, it's not like I don't think it makes as big a difference with something or anything, depending on anything else I can do for you. There's the door this way, or is there something else you want from me? I mean, it depends on how you word it. If you truly are asking them, and you know, oftentimes it's only a few more minutes. Say, yeah, I got this little rash where you look at it. Oh, you got tinea versicolor. Let me give you 1 dose of ketoconazole, you're done. Okay, I'll prescribe that, or I'll give you a dose here. And if you are, you know, kind of a medical economist sort of person, hey, that's another billable diagnosis, and you help them. They don't have to go wait somewhere else, so that's a good thing. So what about providing explanations? That's important. And what's important to people are providing specialist referral. And these things, interestingly enough, are all measured by Press-Ganey. They hit this on the head. If you have somebody who you think has internal derangement of their knee, you think they have a cartilaginous injury, should you send them to the orthopedist or should you send them to the family doc? What do? A lot of us send them to the family doc. Well, do you think that's helpful to the patient? Now they can go see the family doc, says, wow, you should see an orthopedist. Then they go ahead and get the referral, and 2 weeks later they see the orthopedist. You will get a bad survey for that. That's been proven by Press-Ganey's data. If you know they need to go somewhere else, then go ahead and send them there. But you don't want to piss off your medical staff either, so how do you address that? I can send you to your doctor if you want to, and to have them refer you. If you would rather, I'll go ahead and send you myself, and you document that in your medical record. Yeah?
the risk issues with that for follow-up? They sort of get lost.
Sure. Risk issues with follow-up, you're meaning regarding sending to the specialist?
Or who do they go back to for their ongoing care?
I think if you, out of the ED, if everybody gets really 3-day follow-up or less, and you provide them with timed, specific follow-up, you've done the best you can. It doesn't matter where they go necessarily. And if you know they need a specific service, it makes no sense to send them back to the gatekeeper. It's a wasted day for them. Now they lost 2 days at work. I mean, if it were you, think about it. You know you needed to have something done with your knee. You already got an opinion from one physician, and you can go to another physician to have that confirmed, not what the problem is, but that you need to see another physician. That would aggravate me. I'd put ones on a survey once I figured that out. The key is to get the survey out quick so they send it back in before they go to the family doc. You know, maybe you'll get a better survey that way. All right. Communication is key. You look at all the data on this as well. Communication is one of the primary drivers. We've got to talk to our patients. McLeod, abstract number 2, they said that rating of humanistic qualities in the residents by their attendings really correlated with patient satisfaction. If they were humanistic qualities, whatever that meant, they were nice, or something they perceived in that resident to be humanistic, the patients picked up on it also. McDaniel, abstract number 8, kind of interesting. They said self-disclosure, although you're communicating and you're talking with the patients, don't do it. So you've had a bad day and you kind of start going into these things with the patient. They don't want to hear it as much as they will listen. Because they respect you, they don't want to hear it. Listen to the data. The patient said 85% of the time it was non-useful. They didn't talk about how humorous it was to hear about the doc's life. They didn't go into that. But it was disruptive 11% of the time. They won't tell you because of the respect they have for you, but you're wasting their time. Good example. I had a doc that worked for me several years ago, and a patient came in who was suicidal. Didn't commit suicide, just needed medical screening. And this doc at the same time was going through a wicked divorce. And the patient came in and said, well, why are you suicidal? My wife and I had a fight and we're getting divorced. And he goes, yeah, brother, I'm right there with you. And my wife, my ex-wife, I'm going through this divorce. She's a B-I-T-C-H. I bet she's just like your wife. And they went back and forth like this, and they were like blood brothers. I mean, it was ridiculous. Here's what happened. The wife comes in about 30 minutes later, and they do like a Charlie Sheen reconciliation right there in the ED. I love you. I'm so sorry. Let's go home, honey. Next day, who calls the CEO of the hospital? The wife. That doctor called me a bitch to my husband. You know, you got to be careful. Don't disclose all this stuff to the patients. They don't want to hear this stuff, and be careful. Do they want you to talk to them about stuff other than medicine? They do. If it's a work-related injury, do you enjoy your job? Say one thing that's outside of medicine a little bit, and you've made a contact with them. But this isn't the time for interpersonal sharing, though. You know, oh, you have a rash? I have one too. Want to see? No, that's not what they want. They really don't. Okay, another one here, Griffith, abstract number 3. Now, they said really nonverbal communication is important too. You know, if you spend 30 minutes with 1 foot inside the door and 1 foot out trying to get out the whole time, or 5 minutes of undivided attention with eye contact, sitting in a chair, leaning forward, interested, who's going to give you a better survey? The person to get 5 minutes of undivided attention, they really will. And he said certain things like facial expressions, eye contact, smiling, nodding, body posture, tone of voice, all contributed to good patient satisfaction. Another quick anecdote for you. Several years ago, we survey all of our docs, all visits, 100% of visits, through Press Ganey. And we had one site that was just doing miserably, but one shining star doc. He was doing great, 99th percentile. The whole rest of the department was like 12th percentile. So our chief medical officer at the time traveled to this site to say, I got to figure out what this doc's doing, and we can cross-pollinate what this doc is doing to the rest of the docs and fix the site. What the chief medical officer did not know until after the site visit is the doc had Tourette's and had kind of a tic. So she sits down to meet the doc, and she realizes every time you sit down to have a conversation with him, he just nods his head. Eye contact or not, you're like, he always listens. He could have a Rubik's Cube going on and it wouldn't matter. This man, so he always got great surveys no matter what. So a positive, you know, of the nodding with the tics. So body language is very important. Hopefully you don't have to have Tourette's to do it. All right, a few other issues. Let's take a look at abstract number 5, Reed. They looked at 60 emergency department patients with telephone follow-up on these people. And with them, they were questions about their satisfaction of the care provided. 80% didn't seem to care whether they were seen by the nurse practitioner or the doc. What does that tell us? I'm not sure. They were either really seen by really great nurse practitioners, or maybe they didn't know what the doc may have been able to provide. Another article like that by Councilman, abstract number 6, 111 ED fast track patients, said they were cared for primarily by the PAs, and their satisfaction scores were 93%. They're pretty happy. What's scary is 88% said, I wouldn't wait 10 minutes more to see the doc. Again, it's either because they're really satisfied and it seemed like they were, or they don't know what the doc can provide. We have to be a little bit careful sometimes about not interjecting ourselves in the process when we can. But there is some discussion out there about whether the doc will be more satisfying to the patient or not. It appears by these two abstracts, no, if the mid-level provides good service, the patient's going to be happy with that. All right, let's touch on abstract number 9 for just a minute. Does physician uncertainty affect patient satisfaction? Well, they looked at 304 patients kind of waiting for an appointment, and they gave them 5 videotapes to watch regarding whether the doc was going to decide whether they needed prophylactic antibiotics for an upcoming dental procedure. Kind of a weird scenario, but nonetheless, they looked at whether the doc was kind of wishy-washy or whether they said, yes, you need the antibiotics. The highest rated visits were the one where the doc said, yeah, you need antibiotics. Or they left the room and they didn't prescribe antibiotics, but they were specific about it. So that just told them, be specific, don't be uncertain. It freaks people out when you're like, let me go check the computer and see if this is a good treatment plan for you. They do not like that. They want to make sure that you're competent. And the worst rated one's hilarious. When the doc said, hey, we got nothing to lose, so we'll go ahead and use some antibiotics for you. That's a quote right from the abstract. All right, couple things on number 10. 475 undergraduate students, 74 university clinic patients, and 131 medical students who were surveyed, and the physician's diagnostic ability was rated significantly more positive if they didn't use a decision tool, a decision aid. So if you're going to do it, at least don't do it at the bedside. If you're going to bring a chart in and write on it, they love that. Wow, they're interested, they're writing down what I have to say. What I have to say is important. When you're deciding, oh, I don't know what test we're going to order because the computer hasn't told me yet, that does not engender competence. All right, so how does provider dress affect patient attitudes? Is there a diversity of dress codes in your departments? Absolutely. I got to tell you a story about one of my co-residents when I was at Charity. It was a guy that was doing more moonlighting than anybody else. I can't mention his name, but this guy would go to a certain place in Lake Charles, Louisiana, in the bayou, and he would bring his potbelly pig. That was his pet. And he would go to the helipad up on top of the hospital with a pager. And he would have his lab coat on, flip-flops, and a Speedo, and he had one of those metallic things that reflect the sun rays. And they would just page him when a patient came in. He'd keep the Speedo on, throw his little terry cloth robe on. You've seen the people run around here with him on, same robe, and go down and see the patient. That dress code is totally unacceptable, particularly if the little sashy thing comes loose. That would be just ugly. But what do they want to see? I'll summarize all of these for you. There are a bunch of things that we can really focus on, but there are a lot of data out there, and I provided some additional information regarding some of the authors here, but let me just put it in a nutshell for you. People want to see a lab coat. They oftentimes want to see a necktie for docs, for male docs. For female docs, they want to see, maybe a tailored pair of trousers or a skirt. For whatever reason, they've specifically said they don't like mini skirts. So regular, traditional type of skirt, fine. And they want to make sure you're well groomed. Those are kind of the things they want to see. No tennis shoes, no sandals, no flip-flops. Crocs aren't working anymore. I know it was kind of in, but people aren't liking that stuff. You also don't need to go to the business suit attire either. They're focused on what they call professional attire. Lab coat, nice shirt, pair of pants or a skirt. Skirt if you're a female doc. Pants. I mean, I got to clarify. I don't know what that would do with your surveys if you showed up with a kilt on. I don't know, depending on where you're practicing.
Yeah. These go into the lab coats with, at our UC, 40% peds, and that's just drilled into us about, don't even think about coming in with a lab coat. So it's like, you got to be like Superman, like every time you're changing your coat or taking it off.
No, it's actually what's really interesting. There are a couple authors, one of them, Matsui, they even looked at this and said, are kids really afraid of lab coats? No, they're not. They're afraid of you if you're mean to them. Where you're left, they don't have any problem with that. There was one article looked at ages between 4 and 8. They preferred the lab coat. That's the person who's going to help me. So no, it's not a problem. I think it's more of what you do and how you approach them. What I think is important with kids, don't tower over them. Kneel down, sit down, let them be above you, and it takes away a lot of the fear. They don't fill out the surveys either, so you need to be pleasing the parents also. Make sure you're doing that. That's very important. What else? What about the actual necktie? Necktie is kind of interesting. An author, Pronchik, looked at specifically the necktie, and I think in the past, the other articles looking at professional attire just lumped it in there. And he looked at the necktie and found out it really didn't make a difference, but it was a great collinator for community-acquired MRSA. So have you ever gotten stuff spilled on your favorite tie and you're like, that's right, I can get a few more wears out of this thing. Get rid of the tie. So you don't need the tie as long as you're doing the other things, but really a lab coat I think is important. If you're working in an urban center, sometimes there's one article that said it really didn't care much if you wore scrubs or not. They didn't care so much about professional attire. One article said that. And if you show up between 11 p.m. and 7 a.m., they were less likely to care what you were wearing. So if you're working night shifts, yeah, you can probably wear scrubs or whatever. Also in pediatric patients, the parents cared that if they came in with a surgical problem or it appeared to be a surgical problem, they really liked it if you're wearing scrubs because you're a surgeon now. So, but you can't be a surgeon and get a good survey, right? I mean, that doesn't make any sense. You just don't have the personality for it. All right, so what else can we talk about here? Not much else regarding dress, but the key is, interestingly enough, patients don't really care for earrings with male physicians. You know, if you have them, I think it's fine, but are you going to have to, kind of work an uphill battle a little bit to try and win their trust? You may. It's not right, but it's a perception thing. Is there a link between complaints against a provider and malpractice? Do you think there is? Yes, absolutely. Our current system doesn't allow any other way for a patient to get satisfaction for a problem except to either call the CEO, write a letter to the editor, which are not satisfying at all. And if no one gives them satisfaction, they call an attorney. And I'll tell you, once the time clock starts with the attorney and you see the bill and the attorney says, listen, I think we need to pursue this, otherwise you can just pay me out now, otherwise I'll just take whatever I can get from the settlement. Once they're involved, trust me, you are very unlikely to get them out of the picture. They're very good about staying in the picture. So how can we not get them in the picture at all? Patients are not good judges of medical care, but they are fairly good judges of whether you cared about them or whether you tried really hard to take good care of them. And that's what you have to impart to them. It's very important. The scary thing is, and again as a risk manager, and we own our own risk retention group and we insure all of our own docs, the scary thing is the least contributing factor to a claim or a lawsuit is the medical care that's provided. Honestly, that's the case many, many times. What two things will make you more likely to have a lawsuit than anything else?
Doctor was a turd and he had a bad outcome.
The doctor was feces. I'm going to clean that up. Okay, the doctor was a turd. Yeah, you have an unhappy patient and you have a bad outcome. All kinds of patients have bad outcomes. It doesn't make it your fault or your fault. But if you're a jerk on top of it, they're looking for somebody to blame. And if you leave the door open always, like for instance, not using the term diagnosis, we've gone away from that on every one of our charts. You're here, I'm seeing you for a short period of time, I have an initial impression, or I have a diagnostic impression. This is not a final product for you. Your abdominal pain could be A, B, and C. I know based on the testing I've done, it's not X, Y, and Z. But you need further testing. If you get worse, come back. And by the way, anytime there's abdominal pain, always mention the word appendicitis. If you miss it, you'll be a hero for considering it. If someone else discovers it 2 days later when it's obvious, you'll be an idiot. You always got to talk about it. And you'll engender trust with them by doing that. All right, so what are we going to talk about here? Abstract number 11 from Moore. 104 obstetric patients that were surveyed. Kind of another weird little study they did. They gave 4 scenarios to these obstetric patients with bad outcomes with deliveries of the babies. The babies all had varying degrees of problems from the delivery. And if the doc had nice attributes explaining this to them, well then the patient said they wouldn't have sued and they still had good satisfaction. And if the docs came in and they were just not nice about delivering the information, not sensitive, they were very likely to sue based on this survey they did. So it's maybe not a direct correlation, but at least it's asking the patients, what would you do if you were approached this way with these scenarios? So you got to try and be nice. You do. Vanderbilt University published abstract number 12. It looked at physician risk management files and compared those to complaints. This is interesting. I think you'll like this. 63% of physicians had at least one complaint. Okay, so there were a good number of docs that didn't have it at all. Some of these things won't surprise you. The surgeons had twice as many complaints as the non-surgeons. Anybody just, I don't see any mouths wide open there. I mean, that makes perfect sense to me. 13 per provider for the surgeons, 5 per provider for the non-surgeons, and more than 50% of the complaints were generated by 9% of the docs. Is that also a surprise to you? Does everyone have the grumpy doc in their department? You know who they are. It might be you, I don't know, but if you have the grumpy doc, we all know that that's in that 9% right there. So what they found too is that basically there was a significant correlation with opening risk management files and claims and problems when you have more complaints. They tracked it. Stelfox, Abstract 13, took it one step further and actually looked at complaint rate and looked at risk management events specifically, claims, money spent to defend you. And there was a direct correlation with patient complaints. Matter of fact, something that was really interesting that they found, 1-point reduction in patient satisfaction scores equated to a 6% increase in the provider's complaint rate. It makes perfect sense. They're unhappy, they're going to complain. And if they're complaining, they're at a new level where they're likely to file a claim against you if there's a bad outcome. Our patients will have bad outcomes. We have no way to prevent that. We're only seeing them for a snapshot of time. But you've got to plan your day and their expectations accordingly. We may not have identified your problem. Come back if you need us. This isn't a final product for you. Okay, a couple more to go through. You guys have a few more minutes? No pressing matters that way? Okay, good. How do patients or parents' expectations regarding the nature of the encounter, receipt of tests and prescriptions of medications affect patient satisfaction and their satisfaction with the care? Is that a problem if you give the prescription or not? Do you think it's going to impact things? I think it's a big issue for us. Abstracts 14 to 26. I mean, patient expectations are important. But what's very interesting with all of these abstracts is we do not do a good job of anticipating what those expectations are. One of the first things you should do, and I think any visit, particularly one where you know the expectations may not be met, like abdominal pain, they want an answer. They've had abdominal pain for 15 years. No one's got them the answer. I'm glad that you feel I'm that freaking smart, but I'm not going to have any more success than the last 30 people. You've got to find out what the expectations are up front. What can I do for you today? Well, I'm just hurting. I just want out of this abdominal pain. Can you give me something for pain? I can do that. No problem. I want an answer today. It's time to pull up the chair and say, I'll look for an answer, but it's been going on for 15 years. I'm probably not going to find an answer. If they're in your department for 6 hours expecting to get an answer and they get discharge instructions with a prescription of Ultram, they're going to be unhappy. They wanted answers, and you've got to identify the expectations, and you have to do that, you have to talk to them. You actually have to speak with these people and ask them that question. I want to make sure that we meet your expectations. What were your goals for coming in today? You be careful with that question. What do you want? I mean, that is not the way to ask that question. They kind of shut down a little bit. All right. So what else can we talk about with this? Out of sight, out of mind. If we're not really thinking about these discussions and having expectations aligned, then we assume, oh, they won't even think about it. You have back pain? What I do, and maybe this will help you, is if you know there's a preconceived notion that people are going to get something when they come in, the URI discussion. I had it right off. So you're probably wondering why I don't want to prescribe antibiotics. Well, there's no sign of a bacterial infection. Antibiotics don't work for viruses, and I could harm you long-term, whatever, resistance, whatever you want to get into. But just because they don't bring up the antibiotics doesn't mean they're not thinking about it. The x-ray with the knee pain, the x-ray with the back pain, they're thinking x-ray. So go ahead and bring it up. They're coughing, they're thinking chest x-ray, guaranteed. Just bring it up and discuss it with them and realign the expectations, very important. You look at Dowd, Abstract 16, they concluded that increased utilization does not correlate with satisfaction. Interesting, sometimes we think if I just get out of the room and I just order a lot of tests, they'll know I worked hard for them. Absolutely, it has a potential negative effect, particularly if the patient perceives this to be a substitute for quality time with you. All they want is your love. Just a little time. I waited in here for an hour for you and you won't even stay. You'd rather check boxes and spend my money. They really do want care and quality interaction with you. And a good explanation for why you don't need a test goes a lot further than ordering the freaking test. It really does. It really does. Provider humanism by Frolic in Abstract 17 was defined as really the sole significant predictor of patient satisfaction. You got to talk to these people like you talk to somebody that you want to spend time with. So you got to, that was a joke, but you know, you don't have to spend forever with them, but when you spend time with them, you got to have some eye contact and truly try and help them and find out what the root of the problem is. All right, patients inappropriately expect antimicrobials many times with upper respiratory infections and bronchitis. You look, there's a series of abstracts here that kind of go through this, and again, good communication is the key, and they really want an explanation. Even if they expected the antibiotic, The predictor was, did you have a good explanation and rationale for the care? Not if they got the antibiotic or not. Look at all these abstracts and it will tell you exactly that. They're fairly consistent. What we are horrible about is assuming who really has the expectation. One of the abstracts said, well, you know, what are the predictors of someone thinking that they want antibiotics? The doc thinking they want antibiotics. If the patient or the parent of the patient comes in with a predefined diagnosis, I think my child has an ear infection. Has anyone ever heard that? Well, do we automatically say, they want an antibiotic? They already want the antibiotic. But if you look at this article, no, they're not saying that. They don't know the medicine. They're just giving you some leading information to say this is where we're headed. To them, that's the same as a complaint. But to us, it's a diagnosis. The other thing is if you offer treatment, just symptomatic treatment for viral type of symptoms, they don't care for that so much without a good explanation also. But the big thing is, it's not about the antibiotic or the prescription. It's about your explanation of the care you're providing. You'll never get around this. You've got to explain what you want to do with them to let them know you care and have a reasonable rationale for doing this. And if you can do that, they'll accept a lot of what you want to do. All right, abstract, we'll skip way down to abstract 21, and they talk about the contingency antibiotic prescription. And there's some good literature out there right now with otitis to say, you know what, they got a little bit of a red ear, you think they have otitis, it's a good chance within 48 hours that's going to go away anyway. Give them the prescription. If they're not better, either follow up back here or go ahead and fill the prescription, and you can do that. And if you get somebody who's really battling with you, I get the same thing every year. They always prescribe the Z-Pak and it always gets better. Why won't you? You don't need to get into a knockdown, drag-out battle. It's probably coincidental that it's gotten better every year and they were happy to be on antibiotics at the time and say, all right, you may not need it. You've only had your symptoms for 12 minutes. But let's do this. If you really feel that's the case, give me an opportunity to see if symptomatic treatment will help you. Here's the prescription. Only fill it if your symptoms are not better after 5 days. At least it's a middle ground. You're letting them know you're trying to address their needs, but you're trying to do it in a more responsible way. And using a prescription as a closing strategy, absolutely don't do it. Don't do it. They say in these abstracts, one in particular, that if you say, all right, we're not getting along, you really want this, you're not understanding my explanation, ta-da, here's the prescription. It doesn't bring any value to the visit at all. It's because it may not be what they want, because what they really want is your undivided attention, your time, and your compassion. All right, abstract 22. How about sore throats and antibiotics? Now, this is way back in 1998, but nonetheless, they interviewed 21 general practitioners, and they said, well, why do you keep prescribing antibiotics, and why don't you have conversations with the patient? And they said here that most of these docs they interviewed suggested that the evidence isn't clear yet on this viral stuff. It kind of was, but it's even more clear now. And they said it's far too much work to talk to the patient about this. It would unnecessarily prolong the visit. That's what they said. To do the wrong thing, you want to send them home sooner? That doesn't make sense at all. And even back in 1998, that's what some people were saying. You are obligated to explain why they don't need it. It doesn't take long. Just explain it to them. All right. Abstract 25. And this one, avoidance of the term bronchitis. I know this is one of Rick's favorite articles. If you do term it differently, you've got two options. Either term it differently. You have a severe case of acute sniffles, or you have a chest cold, whatever it is, but don't use things that people equate to a bacterial infection. I take the other approach. If I use the term bronchitis, or I don't use the term bronchitis, let's say, or sinusitis, the next doc's going to have to deal with it too, because they're going to say you have bronchitis, or the patient thinks they do. My approach is, you know what, you have bronchitis, but you know what, there's been a lot of literature done on this, a lot of research. 98 to 99% of these, even if you're a smoker, are caused by viruses. And here's what we'll do, it'll make you better. If you're not better, come back. I don't want to harm you by the unnecessary prescription of an antibiotic. Are you comfortable with that? Because I think it's better care, because I don't think it's going to help you. Almost every time they're like, yeah, that's fine. But you let them know, educate them, bronchitis is not a bacterial diagnosis. And now the next doc doesn't have to do that for you. I've been having the sinusitis talk. You know what? Unless you've got frontal sinuses or ethmoid sinuses or you're diabetic, this is sinus congestion. There's really no such thing as a bacterial sinusitis. So we need to treat your symptoms. You don't need antibiotics. How long did that take to explain? Particularly for me trying to get through 52 abstracts in under 30 minutes, it doesn't take long at all. You talk really fast. But you can do that with these people. And all right, abstract 26. We're getting down to the end here, I promise. Satisfaction, antibiotics for URIs, 959 patients. This is kind of a scary abstract. 8 at VA sites and 8 locations that were matched locations to the VA sites at non-VA EDs, and they did telephone follow-up later with a 5-point Likert scale, and the non-VA ED patient satisfaction was better if they got the antibiotic. But we don't know if they tried to explain otherwise. We're not sure exactly what the reason is there. It just tells us we have a lot of work to do. We've got to do the work to let people know why they're not getting it if you don't feel comfortable with it. But clearly the answer isn't, you'll be happier if I give you the antibiotic. They are clearly not comfortable with that. Okay, what is the relationship between the provision of analgesia and patient satisfaction? Remember, it is their pain, not ours. Oh, you look like you can wait a few more minutes. No, they can't. And we've got to make sure it's been well documented that there are a lot of delays, and oligoanalgesia in all of medicine, and the ED is one of those places where it happens significantly. And take a look at the Joint Commission and CMS. They're all over this thing. There was even one EMTALA violation, I think it was 2 years ago now, where I believe a hospital was investigated. Don't know if they were cited, but they were at least investigated because the patient did not have adequate pain management. Therefore, they were not adequately stabilized before transfer. An EMTALA violation because of pain? Look where this is headed. It's very scary. All right, a couple studies here by Dickesterd and Jones, abstracts 27 and 28, looked at educational programs. If we educate the staff about being acutely aware of pain and how to address it and tell them what to do about it, come get the doc immediately when the kidney stone patient arrives in the ED, does it impact analgesia and patient satisfaction? And the answer is unequivocally, yes, it does. It positively impacts it. So we need to address pain better. In 2001, the Joint Commission jumped in and said, you know, for all hospitalized patients, we have to have a hospital pain management program to make sure you're not missing this. As much as we hate a lot of what the Joint Commission does, it's probably a good idea. We've been ignoring pain because we can't feel it. When it's our pain, how long would you tolerate this? I don't think we'd tolerate it very long at all. Timing and adequacy are the two issues, the critical issues. Timing, and let's get enough pain medicine into them. American Journal of Emergency Medicine, September 2001, abstract 30. They looked at 458 patients, and those patients reported on the average 23 minutes was a reasonable time frame to wait for me to get something for my pain. We know you have to process this. We know you got to start the IV or whatever it is, the saline lock, whatever you need to do. 23 minutes is okay. The unfortunate thing is with the same study, the average time was 78 minutes. If you have your kidney stone, how long is that going to feel like? Anyone here had a kidney stone? Or no, I'll say no, anyone who's had a kidney stone besides your patients? I haven't, but I've seen those people, and you have. You can't make them wait 78 minutes. I don't think you can make them wait 23 minutes. And satisfaction is much higher when they felt like their pain was adequately addressed. It really is. Okay. They also highlighted in abstract 33, the challenging task of measuring pain is a real issue. There's no objective measure. Yeah, let's look at pupillary size. Your pupils are not dilated, you are not in pain. You can't do that. It doesn't make any sense. We have to rely on what the patient tells us is their pain. And what's concerning to that end too, 71% of patients in this abstract reported good or very good pain management. Wow, I got good care, I got good pain management, but when you looked at their visual analog pain scores at the baseline at time of admission and the time when they were discharged, they didn't correlate with good or great care or good or great pain management. So what that tells me is they're having a real problem translating what their pain is to us and what it should mean to us so we can treat them effectively. There's a disconnect here between the patients and us that's not going away anytime soon. My opinion is, when in doubt, overtreat the pain provided it's medically safe. Don't undertreat it. All right, what additional factors relate to patient satisfaction with ED care? Abstracts 34 to 46, we'll hit them all at once here. Here they are, explanation of test results. If you order a test, you owe them the opportunity to know what the result is. It's kind of like going to a restaurant, they hand you the menu, you order all this stuff, and you flag down the waiter and say, hey, when's the food coming? Oh, no, don't worry. We prepared it, it's really good, we're eating it back there. But you don't need it, but here's the bill. You know, I'll be honest with you, you should be showing results to your patients and treat them like people who are reasonably intelligent people that might understand these things. Just takes a minute. Here, look, your CBC, it's normal. You're not anemic, look at this number. And the white blood cell count, the infection-fighting cells, they're not elevated. Whatever you want to do, show them their test and talk to them. Discussion about reasons for returning to the ED. What are the parameters? If this or this happens, come back. Use simple language and explanations. Don't get into detailed medical terms. You're just talking to people who don't know medicine, so explain it to them. Explain the rationale for diagnostic tests, and beyond that, the other things that we want to focus on are wait times. We know people are unhappy if they wait a long time, right? And you can be forced to do a lot of service recovery if you're not an efficient doc. You know what's more important in all the patient satisfaction literature is not wait times, it's perceived wait times. So if we do something whippy-skippy special with their time while they're waiting and keep them occupied, TVs was the first thing. Let's throw a TV in the rooms, they'll be fine. It helps, but make sure there's some value to what to the time that's being spent, and if they perceive less wait time, they will be happier, and it's irrespective of the actual wait time. Another quick strategy, turn off the clocks, make them run slower, turn them back, whatever you need to do. But if they have a perceived wait time that's less than it actually was, they'll be much happier people. So do something with their time if you can't fix the operational inefficiencies in your department. Very, very important. Early nursing interventions are important, so if you can get some standing orders up front, get things started, that's important. But please remember, and this is not a slam at all to the mid-level providers or anyone else or to any nurses, but most of the patients, based on these abstracts, said the care really doesn't start until I see the physician. They come to the ED to see the doc. So you're going to have to figure out a way to get in the same room with them on the front end of the visit, not way on the back end of the visit. Very important. Abstract 34, lower acuity patients expected shorter wait times. If you're just here for an ankle sprain, you can wait. Absolutely not if you're focused on patient satisfaction. You are a 5 to 10 minute visit for me. Let me take care of things and get you in and out of there. That's all they're there for, is to get that taken care of. They shouldn't have to spend a lot of time. Abstract 35, 1,574 patients. They completed telephone interviews 2 to 4 weeks after the visit. Honestly, we do phone follow-ups. They should be within 48 hours, 72 at the outside max. Patient satisfaction was increased when waiting times were shorter than anticipated. So here's what you do. You've got to let them know. Use the Disney principle. If you go in there and try and please them and say, they say, well, how long do you think it's going to take today? It's only going to take an hour, I promise. Or the nurse will be right in with your pain medicine. You are setting yourself up for failure. Use the Disney concept, and you have to provide good value for their time and overestimate. So you under-promise and over-deliver. You know what? You got some lab work we're going to do. We're going to treat your pain. We're going to get a CAT scan of the abdomen. You know what? It could take a while to get the CAT scan done and to get the results from radiology. Sorry, I don't control that department. I'll do the best I can to make that move along more quickly, but I'm not in control of that. And if they're going to be slow and you're going to be responsible for it, at least give the radiologist or whatever the slowdown is the accountability for it. I'll make it go quicker, but hey, that's radiology. It's not us. Whatever you need to do, but let them know. So it could take the better part of 3 or 4, maybe 5 hours. But if you got these tests as an outpatient through your doctor, it would take 2 weeks. It's the case. It's absolutely the case. By the time they got it ordered and everything, I'm telling you, people like that. And then when it's really done in 4 hours, like, wow, this is quick. This is great. So you guys are really fast today. Yeah, absolutely. Another strategy is, do you ever look at the chart to see how long people are waiting before you get into the room? Quit looking. Apologize to everyone. Walk in the room, sit down, hey, I'm really sorry for your wait. One of 2 things is going to happen. Either they waited a long time, and they're going to say, yeah, that's okay. We understand you're busy. We've seen you running around back and forth. Or, I've only been here 5 minutes. Wow, this place is a well-oiled machine. So either way, it's a positive for you. So just apologize to all of them. All right. What else in this section can we talk about as a value to you? Abstract 38 is probably worth mentioning. There were exit questionnaires completed by patients, and they reported here that they had good or excellent care, and they said the mean satisfaction rating on a 1 to 5 scale was 4.24, and the significant predictors of satisfaction were, interestingly, if the patient was of Caucasian race. Older patients tend to rate us a little bit better. Maybe they have a little more time on their hands, I'm not sure. A visit for well care rather than for an illness. We're behind the 8 ball with that. They mostly come to us for illnesses that are acute. And duration of the visit, and here's a good one, chatting. There were at least 2 abstracts or 2 articles I'm aware of that talk about a little chatty behavior from you. Don't do the disclosure thing. But if you chat with them a little bit, just one thing, you're suturing them, dead silence when you're suturing, oh, it's awkward. Talk to them a little bit. How many kids do you have? You're spending time anyway. So go ahead and chat just a little, and that's a huge, huge winner with the patients. It really is. All right. Abstract 43. Willingness to return to the ED was significantly reduced when patients were not happy. That's important because that's what your CEO wants, the return visit. These patients in this abstract did not if they didn't receive help when they went to the index ED visit, the first visit, if they felt like they just didn't get what they needed, they're not coming back. Another predictor was they received inadequate explanation of the possible causes. They were not informed about wait times. They were not told when to resume their regular activities, when to return to the ED, all of these things, and inadequate explanations of test results. This should be just part of your natural repertoire with taking care of these patients. You got to hit these elements. All right, abstract 45, total time spent in the ED was not significantly associated with patient satisfaction. Being cared for was. They will spend a lot of time waiting for you if they feel like they really got some valuable time with you. It's quality time. It is. They expect that. All right, so you guys ready to be done? We're almost there. Abstracts 47 to 51. We'll lump these together pretty quick. What other practices are likely to improve satisfaction with the care in the ED? Abstract 47 was way back in 1978, but still a great idea. The ombudsman. It's the patient care representative. If you can't pass out blankets or water because you're too busy, have somebody running around taking care of the personal needs of the patient. And certainly take advantage of that and also take responsibility for it with the patients. Hey, listen, I've got a patient representative. You want some water and a blanket? I'm a little busy right now, but I'll make sure that this person comes in and takes care of what you need. And do that. It's a great satisfier. It doesn't cost much. The volunteers can do it as well. How about crowding? Looking at abstract 49, is that an issue for us? Absolutely. You need to be following your metrics so when your department is coming unglued, the wheels are coming off the bus, and the length of time is going up, your patient satisfaction is dropping through the floor also. And if you monitor those metrics and fix those, you're likely to improve your patient satisfaction. Telephone follow-ups, abstract 50 and 51, they do work great. You can identify gaps in care, and patients love it that you call back and check on them. But abstract 51 gave you one caveat. They found 21.1% of the phone numbers weren't even any good. So this may not be the best way to do it. And dialing it doesn't help. Well, I tried, so I'm sure they're appreciative I tried to get a hold of them. It really doesn't work. You've got to actually talk to the person. All right, and the final abstract. You guys are weepy. It's the final abstract for patient satisfaction. Is there one study that best summarizes the literature regarding satisfaction in the ED? Great article by Boudreau in Journal of Emergency Medicine in 2004. Basically, interpersonal interactions between the physician and the patient, including verbal and nonverbal skills, perceived waiting times, and effective delivery of information are the key elements to patient satisfaction, what you need to focus on to satisfy your patients. I appreciate you hanging in there. I know it's been a long day. Thanks, everybody.